Well, hello class, and welcome to this video on treating patients' hypertension with antihypertensive medications. When we think about hypertension, we think about that prolonged, persistent pressure within the arteries within the body and the damage that that can cause. We know that having high blood pressure, persistent high blood pressure, can lead to coronary artery disease, causing heart attacks, stroke, kidney problems. So we need to get a hold of our patients and caring for them when they have hypertension. We know the things that lead up to hypertension are smoking, too much salt in the diet, not an active lifestyle, genetics, smoking, all sorts of different things cause hypertension. So we need to be able to figure out how to help our patients with hypertension and get that blood pressure down to a normal range. They don't have long-term consequences of a heart attack, stroke, and kidney disease. Most people that have hypertension don't even know that they have it. Um, it is a silent until they have a heart attack, usually, or a stroke. So we really need to think about that before we even talk about the patients with medications, because when they're on these, we need to make sure they stay on them, that they're being compliant with the medications, that they know about the side effects. It's all very important. So before we jump into the medications, you want to kind of think about this. Backing up, think about blood pressure as a garden hose. And the hose is the arteries, and the water would be like the blood. And things that can cause high pressure in those arteries or that garden hose would be like if there's mud caked up on there, or like in the arteries, atherosclerosis, plaque, narrowing of the arteries, constriction. Um, so I think it helps when you think about it in a very logical kind of a way. So there's multiple different classifications of antihypertensive medications, and you are required to learn one drug from each of the different antihypertensive classifications. So there's ACE inhibitors, and you are to learn captopril, and remember these end in the suffix pril, P-R-I-L. And there's angiotensin 2 receptor blockers, or ARBs, and those end in the suffix sartan, and the name of the drug that you'll learn for that is losartan. Beta blockers, you know from your last modules on neurodrugs, and in LOL. There's more about beta blockers in chapter 46. Calcium channel blockers usually end in dipine, D-I-P-I-N, like nifedipine, but you will be studying about diltiazem, which is also a calcium channel blocker that works a little bit differently. But you always want to remember these suffixes, because if you learn one drug within a class, then you can apply that to all the different medications. So if you see a medication that ends in one of these suffixes on an exam, not in this class, or on NCLEX, or in real life, or in clinical, you'll know how that drug is affecting the patient just by the classification. The renin inhibitors, like aliskiren, vasodilators, nitroprusside, and alpha-1 blockers, prazosin. So in your book, in the card text in figure 43.3, it has a very nice diagram of all the different sites of action of antihypertensive drugs. Your body works to control blood pressure in a variety of different ways. So you want to be familiar with how the body normally regulates blood pressure. And then when you study the different classifications of medications, it makes sense. So just like the neurodrugs, you don't have to memorize laundry lists of side effects. As long as you understand what's happening in the body and what the medication is doing, you will be able to understand why you'll see the action and why you'll see that adverse effect. So very important to understand before we start talking about the antihypertensive drugs is the renin-angiotensin-aldosterone system for blood pressure control. So I'm not going to explain it in detail, but please review this before you watch this video, because it'll make a lot more sense. Excuse me. So let's just think about how the normal RAS system works with someone who doesn't have hypertension. Let's say you have a normal, healthy adult that has normal blood pressure and has an accident and hemorrhages and loses a ton of blood, and so now has low volume. what does the body do to get that blood pressure back up? Well, first, the kidneys say, hey, this is a problem. If we don't get enough blood flow, if this low volume continues, we're going to die. So we know how to help this. So the kidneys recognize that something is going on and they need to help out. So the kidneys secrete renin, and renin then makes angiotensinogen convert to angiotensin 1, and then your angiotensin converting enzyme, or ACE, makes angiotensin 2. Now, angiotensin 2 is this potent vasoconstrictor. And again, think about that garden hose, and it squeezes the blood vessels, which will increase that pressure. Also, what's happening is aldosterone gets secreted, and aldosterone recognizes, hey, we know how to help out this situation too. So we're going to keep sodium. And if we keep sodium, we keep water, because water follows salt, and that will help increase the volume, the blood volume, and then pressure goes up. So while you're remembering the RAS system, we're going to be talking about how these different drugs are going to be interacting at these different points in the RAS system and outside to help hypertension. Okay, so our first classification of medications is ACE inhibitors. So again, think about what those stems of the words mean. Angiotensin converting enzyme inhibitors. It's a long word, long phrase, but if you think about what those stem of the words mean, it'll make a lot more sense to you. So angio means blood vessel. So angiogram, right? Angioplasty. These mean angio means vessel. Tensin, think of tense. So a tense blood vessel constricted. An inhibitor, the inhibitor is going to inhibit that squeezing or tense blood vessel. So angiotensin converting enzyme inhibitors. Remember, the ACE is what gets the angiotensin 1 to convert to angiotensin 2, and angiotensin 2 is that potent vasoconstrictor. So we're going to inhibit the ACE, which is going to not constrict then, and it will end up with lower blood pressure. Again, remember that the drugs in this classification, the suffix, they end in pril, like captopril. And one of the major side effects of this classification of drugs is a cough. And we're going to talk about why patients get this cough in the next slide. But I want you to remember, because this is such a common adverse effect. So the way that I was taught, and always remember, is give them an ACE and they'll cough in your face. Excuse me. So remember that patients, pens up, patients with ACE inhibitors have a frequent cough. And it's not a mucousy cough, it's not a productive cough. It's this dry, hacking, annoying cough. And that's really all it is. It doesn't harm the patient. It doesn't mean that something else is going on inside their lungs. It just means that they have this extra cough. So what's going to happen then with these ACE inhibitors? Well, we know that you are not going to have that angiotensin 2 that's causing that vasoconstriction. So you're going to get that low blood pressure. It's going to drop that blood pressure. It'll cause vasodilation. And when your blood pressure drops, your patients need to be aware of this. So you need to think like a nurse and think about, well, what's going to happen? That's great that they're not going to have this high blood pressure. We're going to give them this ACE inhibitor. The blood pressure is going to drop. But what does that mean? Well, it means that, have you ever been laying down and stood up too fast and you felt kind of dizzy, like you were going to fall over? Well, this is a phenomenon that will happen. We call it orthostatic hypotension, and it happens especially with patients who are on antihypertensive medications when their blood pressure drops. And it happens when they get up too fast. So we want to have them sit at the edge of the bed, dangle their legs, make sure that their body has a chance to get that blood flowing back up to the head instead of just shooting the head straight up out of bed and then having the blood pressure drop too fast. Also, they can have their heart rate increase because as the blood pressure drops, the body is thinking, hey, I know that if the tissues and the organs are not getting the blood perfused as they need to, I can help out and I can speed my heart rate up. And so that compensatory mechanism sometimes can increase the heart rate. Also, what's happening, we know that aldosterone in the normal RAS system will conserve salt and water, right, to get that blood pressure back up. But if we are inhibiting this system, that we are going to inhibit aldosterone, so we're going to see not that accumulation of salt and water, but we are going to excrete that salt and water. So if we are losing more salt and water, then we need to be paying attention to the patients who are at high risk for dehydration. If they already have heart failure, if they already have dehydration, if they are in a situation that makes them sweat more, this can be real problematic for them. So we need to look at their renal status before we start this patient on this medication. Also, because the salt and the potassium are usually opposite, we're going to potentially be increasing the amount of potassium that we have. So we really also need to be very careful about this situation. We want to be watching for what? How do you know if your patient has high potassium that's reached a toxic level, other than looking at their lab values? Right. If they're on bedside monitoring, we can watch their EKG or ECG. And what do we normally see with high potassium that's toxic levels? Right, these peaked T waves. So we may be able to notice that even before an arrhythmia happens. So we want to be careful of that with these patients. When we are monitoring their kidney function, how are we going to know if their kidneys are working okay? Right, we're going to look at their BUN, their creatinine, their urine output. Excellent. Also, another adverse effect that happens due to this situation when a patient is getting their ACE inhibitors, we can also see this angioedema. And angioedema is swelling underneath the tissue, which can look like swelling in the eyes. It can also cause problems with breathing. It can be life-threatening. It's rare. More often we see it in African American patients. So it's just something we do want to be aware of. It can be dangerous for the fetus, so we do want to make sure that female patients are using contraception. And also it can cause a pancytopenia, so we want to make sure that the patients are not having any symptoms of that, so they're not bleeding, bruising, having frequent infections. So we're going to be monitoring their CBC for sure. Okay. And about that cough, we were talking about what is causing this cough, this annoying cough that happens with ACE inhibitors. And it happens because of a substance called bradykinin. And bradykinin is a substance that causes vasodilation, and it is decreased during the RAS. But since that is being blocked in this ACE inhibitor situation, you will see an increase in bradykinin. So that will cause that vasodilation and open up the blood vessels. Okay, the next classification of medications for antihypertensives we're going to talk about are the ARBs, or the angiotensin II receptor blockers. And these end in a suffix called sartan, and the medication name is losartan. So these medications are very similar to ACE inhibitors. So if you understand ACE inhibitors, you can understand the ARBs. So this also will affect the RAS system. Now, it is going to block that angiotensin II receptor. So it's not going to stop the ACE. It is from turning into angiotensin II, but it's going to actually block the receptor of the angiotensin II. So we are going to see that the ARBs block the action of the angiotensin II. So their effects, again, are very similar to the ACE inhibitors by blocking that angiotensin II receptor in the blood vessels. So our ARBs are going to cause that vasodilation And we will continue on the next